Usually when we talk about medical treatments for the skin, there is this expectation of toughness.
Right. Yeah, like it can take a hit.
Exactly. Like if you have a sunspot on your face or, a deep wrinkle, a dermatologist might use a really high-powered laser to essentially just zap it.
Mm-hmm. And that makes total sense to us intuitively.
Right, because the skin on our face is resilient. I mean, it's literally designed to take a beating from the elements, from UV rays, all that stuff from the outside world.
Yeah, our outer epidermis is built as a biological shield. It's got these layers of hardened, keratinized cells that can handle, a controlled amount of surface trauma.
And predictably bounce back.
Exactly. It bounces back.
But then you take that exact same concept, using a laser to intentionally burn tissue to force it to heal, and you move it away from the face.
Yeah, which is a massive leap.
A huge leap. You move it to the internal, incredibly delicate mucosal lining of the vagina. And suddenly, we aren't talking about a tough outer shield anymore.
No, not at all.
We're looking at a medical landscape that is, honestly, it's just incredibly murky. And that brings us to the mission for today's deep dive.
Which is quite the stack of research we've got today.
Oh my gosh, yes. For everyone listening, we have a massive stack of sources in front of us today. We're talking clinical trials in the International Urogynecology Journal to severe safety warnings from the US FDA.
Right. And international ones, too.
Yeah, we've got regulatory alerts from Australia's Therapeutic Goods Administration and New Zealand's MedSafe. And they are sitting right next to these incredibly slick, glossy marketing materials from clinics promoting devices like the Mona Lisa Touch and Thermiva.
So we are synthesizing all of these highly contradictory perspectives to answer one, highly specific and frankly urgent question.
Great. Can too much heat damage vaginal tissue?
That is the core question.
Exactly. We want to cut through all the marketing buzzwords you hear. Words like, vaginal rejuvenation and intimate wellness.
Which sound great on a brochure.
They sound amazing. But we want to look at the hard biological science of applying thermal energy to delicate mucosal tissue. So, okay, let's unpack this.
Let's do it.
Because before we can even begin to understand how heat might damage this tissue, we really have to understand why doctors and patients are applying heat to the vagina in the first place. Like, why are we doing this?
Well, to understand the why, we need to look at a condition called genitourinary syndrome of menopause, or GSM.
Okay, GSM.
Yeah, and in older literature, you might actually see it referred to as vulvovaginal atrophy, or VVA.
Right, I saw that in a few of the papers.
Yeah, it's the same thing. The underlying biology here is that the vagina, the urethra, the base of the bladder, and the pelvic floor, they're all heavily packed with estrogen receptors.
Like they need estrogen to function.
They rely entirely on a steady supply of estrogen to remain thick, elastic, and well lubricated.
So when a woman goes through menopause and estrogen levels naturally plummet, this tissue loses its primary support system.
Precisely. The floor just drops out.
And we should point out for you listening, based on the sources, this isn't just about natural aging, right?
No, definitely not.
This also happens practically overnight for women who undergo surgical menopause or breast cancer survivors who are put on aromatase inhibitors.
Right, which are medications that intentionally strip all estrogen from the body to essentially starve the cancer.
Which is life-saving, obviously. But the side effects, what actually happens to the tissue on a cellular level when that estrogen just disappears?
It is a profound cascading biological collapse. Estrogen normally provides glycogen to the vaginal tissue.
Glycogen being a sugar, right?
Exactly, a sugar that feeds the healthy, protective bacteria in the microbiome, specifically lactobacilli.
Okay, got it.
So these good bacteria eat the glycogen, and they produce lactic acid, which keeps the vaginal pH acidic, usually somewhere between 3.5 and 4.5.
Which is pretty acidic.
It is, but when estrogen drops, the glycogen basically vanishes. So the good bacteria starve and die off.
Wow. Let me make sure I'm really following this cascade. Without the good bacteria producing that acid, the pH of the vagina goes up.
It does. The pH rises above 5, and suddenly the environment becomes incredibly hospitable to bad bacteria.
Like what?
Like E. coli, for example, which leads to chronic, recurrent urinary tract infections.
Oh, wow. That sounds awful.
It is. But the structural changes are even more severe, honestly.
Yeah.
Normally, the protective superficial cells make up the bulk of the vaginal wall thickness.
Okay, the outer layer.
Right.
Sure.
Without estrogen, those superficial cells drop to less than 10% of the tissue's total volume.
Wait, less than 10% of what it used to be?
Less than 10%.
That means you are left with a paper-thin, incredibly fragile lining.
Exactly. There's no cushion left.
Looking at the medical society guidelines, the resulting symptoms just sound agonizing. We're talking about severe burning, chronic itching, and tissue that literally tears and bleeds during intimacy.
Yeah, the clinical term is dyspareunia, which just means pain during sex, and it becomes a devastating quality of life issue.
I can't even imagine. And for decades, the standard, like, gold star treatment for this was localized hormone therapy, right?
It was. You just replace the estrogen locally with a cream or a small insertable tablet.
And then the glycogen returns.
Exactly. The glycogen returns, the cells plump back up, and the microbiome stabilizes. It works beautifully.
But that brings us back to the breast cancer survivors. What if you absolutely cannot take hormones?
Right. That's the dilemma.
Because if estrogen is like the water that keeps a sponge plump and elastic, going through menopause or cancer treatment is like wringing that sponge bone dry.
That's a great way to put it.
And instead of adding water back in with hormone therapy, the aesthetic industry decided to fix the dry sponge by hitting it with a blowtorch to force it to tighten up.
I mean, honestly,
Yeah.
that is a remarkably accurate way to visualize the mechanism of action behind energy-based devices, or EBDs,
Really? A blowtorch?
basically. Whether you're looking at a laser or a radio frequency wand, they all operate entirely on that one underlying principle, transferring immense heat into the tissue.
Okay, so can you break down how they actually generate that heat? Because the sources mention a few different types of technology, and it seems like they interact with the tissue differently.
Sure. The clinical literature primarily details three main technologies. First, you have CO2 lasers, which are microablative,
Meaning what exactly?
meaning they use thermal energy to literally vaporize tiny microscopic columns of tissue, leaving healthy tissue in between to speed up the healing process.
Vaporize. Wow. Okay, what's the second one?
Second, you have ERR-YAG lasers. These are non-ablative, so they hit the water inside the tissue without actually vaporizing or destroying the surface layer.
Got it. And the third?
Third, you have radio frequency, or RF devices, which don't actually use light at all.
Oh, really?
Yeah, they use electromagnetic currents to bypass the surface entirely and generate heat deeper down in the underlying connective tissue.
Okay, but despite those different delivery methods, vaporizing, heating water, or using currents, the biological goal of all three is identical.
Exactly identical.
Because the clinical term they use in the studies is creating a, quote, controlled thermal injury. Literally a controlled burn.
Yes. The entire premise relies on the body's natural trauma response. The body senses the burn, panics, and floods the area with inflammatory markers and growth factors.
Just a total alarm bell going off in the body.
Precisely. This acute inflammation wakes up dormant cells called fibroblasts, stimulating them to produce new collagen and elastin fibers.
And so theoretically, this thickens the vaginal wall and restores blood flow.
That's the theory, yes.
But the margin for error here seems, I don't know, entirely reliant on hitting a very specific temperature. The numbers in these clinical studies are wild.
They are very specific.
Like with the radio frequency devices, for example, they note that temperatures between 40 degrees and 45 degrees Celsius stimulate those fibroblasts to produce collagen.
Right. That's the sweet spot for the controlled part of the injury.
But 45 Celsius is what, like 113 Fahrenheit? That's hot.
It's very hot. And it's a very narrow sweet spot because the cellular biology changes so rapidly as the heat increases.
How so?
Well, if the tissue temperature hits 60 degrees Celsius, collagen begins to denature.
Denature meaning it breaks down.
Exactly. The protein structures literally start to unravel and break down. And if the temperature reaches 70 to 75 degrees Celsius, the collagen completely denatures. It is irreversibly destroyed.
It's cooked.
It is entirely cooked.
Okay, here's where it gets really interesting to me. I was reading the white paper from the International Continence Society, the ICS, which was included in our stack of research.
Yes, the ICS paper is crucial here.
Because the marketing materials for devices like Mona Lisa Touch and Thermiva constantly use the word regeneration.
Oh, constantly.
They claim the heat is regenerating youthful tissue, almost like this magic time machine. But the ICS seems to push back hard on this based on the actual biopsies. Can you explain what the ICS actually found?
Yeah, so the ICS analyzed the histological evidence, meaning the actual cellular biopsies taken from women after they had these laser treatments.
The actual cells under microscope.
Exactly. And they pointed out that what we are seeing under the microscope doesn't necessarily show a true restoration of normal premenopausal function.
So what does it show?
The biopsies show desquamation, which is the complete shedding or peeling of the outer layer of tissue. They show denuding of the epithelium, and tissue coagulation.
Wait, let me make sure I understand this. The ICS is saying that shedding layers of tissue and coagulating cells is actually perfectly consistent with reparative changes after a thermal burn.
Yes.
So it's essentially wound healing, it's scarring.
It is a reparative fibrotic response.
So when a woman undergoes one of these treatments and the clinical trials show that the vagina is quote-unquote tighter, are they just measuring the tightness of a scar? Because scars contract as they heal, you know?
That is a huge part of it, yes.
Or maybe they're just measuring the acute swelling from the burn itself.
The ICS raises that exact concern. The tissue feels thicker and tighter because acute inflammation causes edema swelling, and the subsequent healing process lays down collagen in a way that mimics scar formation.
So it's not turning back the clock.
No, it is a defense mechanism against thermal trauma.
Wow. And that realization that this rejuvenation is actually a wound healing response to a burn, that brings us directly to the core of our deep dive.
The big question.
What happens when that heat crosses the line? What happens when a controlled injury on a paper-thin mucosal lining becomes actual catastrophic damage?
Which is a very real possibility.
Because looking at the regulatory alerts, bodies worldwide have sounded the alarm on this.
They absolutely have. In July of 2018, the U.S. FDA issued a severe safety communication explicitly warning against using energy-based devices for vaginal rejuvenation.
Just straight up warning against it.
Yes. They stated point blank that the safety and efficacy of these devices for these specific conditions have not been established. And New Zealand's MedSafe followed suit with a similar warning.
But Australia went even further.
They did.
The sources show that Australia's Therapeutic Goods Administration, the TGA, which is basically their equivalent of the FDA, conducted this massive post-market review. And they didn't just issue a warning. They found there was insufficient clinical evidence to support the long-term safety of these devices, so they took sweeping action.
Very sweeping.
All energy-based devices intended for vaginal rejuvenation were formally canceled from the Australian Register of Therapeutic Goods. Like, they effectively banned them for this specific use.
And canceling a whole class of devices for a specific indication is a massive regulatory move. I mean, it indicates a severe risk-to-benefit ratio.
Yeah, no kidding.
And when you look closely at the FDA's MOUE database, that's the Manufacturer and User Facility Device Experience database, where doctors and patients report adverse medical events, you really begin to see the horrific reality that prompted Australia to pull the plug.
Oh, the MOUE database reports. The graphic evidence of heat damage in these reports is incredibly sobering.
It's very difficult to read.
The mission of this deep dive was to ask if too much heat can damage vaginal tissue. And for you listening, these case studies provide a definitive, terrifying yes.
They really do.
As I was reading through the MIUD reports, there was a specific medical term that kept popping up over and over: fibrosis.
Yes, fibrosis is the key word there.
There was one report of a 65-year-old breast cancer survivor that just really stuck with me.
Let's look at the clinical details of that case, actually, because it perfectly illustrates what happens when the cellular biology is just totally overwhelmed.
Okay, so the 65-year-old woman, postmenopausal, is dealing with severe vaginal dryness due to her breast cancer treatments. She goes in for 3 CO2 laser sessions.
Right.
A few weeks after her final session, she attempts intercourse. She experiences heavy vaginal bleeding immediately.
Just immediate trauma.
Her doctor actually has to put her under anesthesia in the operating room just to repair 2 severe vaginal wall lacerations.
The traumatic acute injury. But the long-term sequelae are even more concerning.
Exactly. Because several months later, she presents again with severe vaginal pain and an absolute inability to engage in penetrative intercourse. The physical exam showed a foreshortened vaginal canal. It was only 2.5 centimeters in length, and the apex was completely filled with rigid fibrotic tissue.
2.5 centimeters.
2.5 centimeters. For context, a typical vaginal canal is around 7 to 10 centimeters long. How does heat cause the vagina to physically shrink and just seal itself shut?
Well, what you're describing are conditions known as vaginal stenosis, which is the abnormal narrowing and shortening of the canal, and vaginal synechia.
Synechia? What is that?
They are internal adhesions where the tissues essentially glue themselves together.
Oh my gosh.
Think about the baseline condition of this patient's tissue. As we discussed earlier, she has severe GSM. Her tissue is already paper-thin, incredibly fragile, and lacks any protective barrier.
There's no cushion.
Exactly, no cushion. When the heat from the laser is applied too aggressively to this already compromised tissue, it doesn't just gently stimulate fibroblasts.
It just destroys them.
It obliterates the cellular structure. It causes massive acute inflammation. The body's panicked, desperate response to a severe mucosal burn is to rapidly lay down thick, rigid scar tissue to bridge the wound.
Just to stop the bleeding and the damage.
Right. The intense heat literally melts the delicate walls, and as they heal, they scar and they fuse together.
It's horrifying. And there was a second case in the data that mirrored this, a 68-year-old woman who went in for laser treatment and ended up developing a crescent-shaped fibrous band mid-vagina.
Yes, saw that one.
It created a stricture, like a literal physical obstruction in her vaginal canal.
A literal wall of scar tissue.
And it's not just structural damage either. The MIUDD database contains reports of third-degree burns inside the body, severe blistering.
Which is incredibly painful.
Yeah, women reporting that their dyspareunia, their pain during sex, is vastly worse than before they ever got the treatment.
And with the radiofrequency devices specifically, there's another major complication.
The numbness, right. I noticed multiple reports of a total loss of sensation, complete numbness leading to permanent sexual dysfunction.
Yes, the numbness is a direct result of how radiofrequency energy moves through the body.
Because it goes deeper.
Exactly. Because RF devices are designed to bypass the surface epithelium and push the heat deep into the underlying connective tissue, they risk encountering and damaging the underlying nerve networks.
Oh, wow.
If the temperature exceeds that 60 to 70 degree threshold deep in the tissue, you are effectively cooking the sensory nerve plexuses.
So we have the FDA screaming stop. We have Australia outright banning the devices for this use. We have clinical reports of third-degree burns, fused vaginal walls, and destroyed nerve endings.
The list of severe adverse events is long.
It really begs the question, why are clinics on every corner still offering these treatments? Why do some very highly respected doctors absolutely swear by them?
That is the ultimate tension in this entire medical debate. Because standing in direct opposition to the horrific injuries in the MIUD database is this massive counter-perspective.
There's a whole other side to the research.
There is. There are dozens of clinical studies, retrospective reviews of the Photona ARIG lasers and the Mona Lisa Touch CO2 lasers that document statistically significant improvements for their patients.
They use objective scoring systems in those, right?
Yes, very specific metrics.
Things like the Vaginal Health Index, or VHI, which measures elasticity, fluid volume, pH, epithelial integrity, and moisture, and the Female Sexual Function Index, the FSFI.
Right.
And in many of these published studies, those scores skyrocket after treatment. The tissue visually looks thicker to the doctors. The women report less pain.
And we really have to look at the specific demographic that defends this technology most fiercely. The breast cancer survivors and their oncological advocates.
Because they have zero other option.
Exactly. For a woman who has survived cancer but is left with GSM so severe that she bleeds just from walking or sitting down, and she is strictly prohibited from taking estrogen, these thermal devices offered the first real glimmer of hope.
And so when the FDA warning came out,
many physicians reacting to the FDA warning argue that the regulatory bodies were operating out of a, quote, overabundance of caution that created unnecessary panic.
I mean, their argument essentially boils down to statistics, right?
Pretty much.
They say that, yes, the MIUD database contains a few dozen horrific, tragic cases, but hundreds of thousands of these procedures have been performed worldwide.
But they look at the sheer volume.
These practitioners argue that the vast majority of women experience only minor transient side effects. You know, a little bit of edema, maybe a sensation of warmth for a day or two, and then they get their quality of life back.
And they often blame the severe injuries on unregulated med spas.
Right. Undertrained operators who don't understand the exact energy settings required for atrophic tissue rather than blaming the technology itself.
It is the classic medical dilemma. I mean, do you restrict thousands of desperate women from accessing a potentially life-altering therapy just because a small percentage experience severe complications in the hands of untrained operators?
It's a tough question. But I have to push back on that clinical defense, at least based on what the major medical societies are saying in our stack of sources.
You're talking about ACOG and AUGS.
Exactly. Groups like ACOG, the American College of Obstetricians and Gynecologists, and AUGS, the American Urogynecologic Society.
Their stance is very clear.
Yes, we are seeing observational studies with 1 month, 3 month, maybe 12-month follow-ups where women report feeling better. But ACOG and AUGS point out this glaring, fundamental hole in the data.
A near total lack of large, double-blind, sham-controlled long-term studies.
The sham-controlled part being the huge red flag.
The emphasis on sham-controlled is critical here. In a sham-controlled trial, a portion of the women receive the actual laser energy, while the control group receives a fake laser treatment.
Like a placebo laser.
Exactly. The wand is inserted, the machine makes all the right beeping noises, but no thermal energy is actually emitted.
That's the only way to rule out the placebo effect.
It is. And the few robust, sham-controlled trials that have been conducted recently are showing something fascinating.
What's that?
The placebo group often reports subjective improvements in their sexual function and pain levels that are remarkably similar to the women who receive the actual laser burns.
Wow. Which implies that the psychological impact of just receiving care, of being heard and treated by a doctor might be driving a lot of the quote unquote success in those non-controlled studies.
It's a very real possibility.
And even if the heat does work in the short term to thicken the tissue via inflammation, my biggest question is about the future.
The long-term effects.
Yeah. If the International Continence Society is right, and you are essentially causing microscarring to tighten the vagina, what happens to that tissue 5 or 10 years down the line?
That is the million-dollar question.
If a woman gets a laser treatment every single year to maintain the tightening effect, are we just slowly building up layers of rigid fibrotic scar tissue until the vagina becomes totally inelastic?
That long-term unknown is precisely what terrifies the regulatory bodies. The long-term histological impact of repeatedly applying thermal burns to the vaginal mucosa over the course of a decade is just a complete blank spot in the medical literature.
We just don't know.
We simply do not know what that tissue will look like in 10 years.
Okay, so let's synthesize all these takeaways for you listening. We started this deep dive with a very specific biological mission. Can too much heat damage vaginal tissue?
The answer is an unequivocal, biologically proven yes.
Full stop.
Full stop.
Mm-hmm.
The cellular evidence clearly shows that unregulated, improper, or excessive thermal energy applied to an already fragile vaginal lining can lead to catastrophic, irreversible damage.
We're talking severe third-degree burns.
Third-degree burns, circumferential fibrosis, adhesions, and a foreshortened, rigid vaginal canal.
However, we also have to acknowledge the nuance of the gray area here.
There is always a gray area.
In highly controlled settings, with highly specific energy parameters, mild heat is being utilized by some medical professionals to intentionally trigger a wound healing response.
Right, and for some women, particularly cancer survivors with no hormonal options, this provides undeniable, if potentially temporary, short-term symptom relief.
That is the current reality.
It offers relief for some, but it remains an off-label experimental use of surgical tools that carry profound risks.
And that's exactly why this matters to you. This entire deep dive is a masterclass in how to evaluate medical technology as a consumer of healthcare.
You have to be so careful.
Just because a device is legally cleared by the FDA for cutting and coagulating tissue in a general surgical setting does not mean it is proven safe or effective for the off-label aesthetic rejuvenation of delicate internal tissues.
You really have to look past the glossy brochures.
The brochures and the reassuring buzzwords.
Because the marketing language of the aesthetics industry is intentionally designed to soothe. But the underlying physics of the device and the biological reality of thermal trauma, they remain exactly the same.
So what does this all mean for the future of women's healthcare?
Well, it leaves us with something crucial to consider. We live in an era where the lucrative aesthetics industry frequently borrows powerful tools from the surgical ward.
Yeah, constantly.
It forces us to ask, when we use comforting language like rejuvenation and intimate wellness to market a procedure, are we actively masking the biological reality that we are literally burning tissue to force it to scar and heal?
Wow.
And as patients, how do we safely navigate the treacherous space between a genuinely life-changing medical innovation and a beautifully marketed risk?
That is a question we all need to be asking before we let anyone near us with a laser, regardless of what they promise it will fix. Going back to where we started, the skin on your face might be built to take a hit, but what's inside is a whole different story. Thank you for joining us on this deep dive. Stay curious, stay informed, and we'll catch you next time.